Bonjour, bonjour, and welcome to our webinar this evening. We're so very delighted to be talking to you about all things heart. This evening, we're going to jump into the idea of heart disease and what is causing it. And if you're a frequent offender of these webinar series, you know we've talked about this a few times before. And so this evening, we really want to dive into a few risk factors, a few populations where heart disease is very much prevalent, where heart disease, the risk of is changing. And so we really want to highlight those two populations and then talk to, well, what do you do about that, right? So having this conversation with me, diving into the data with me, diving into the science with me. This evening, I have our most wonderful Dr. Varden, and then I also have our most wonderful and soon-to-be He Summit host and speaker, Justin Harris. Welcome, guys. How are you?
Hello.
Hello, folks. Good to see everybody.
Good to see you guys too. And I feel like, and we all know I have about a peanut of a memory, I feel like we've talked about heart disease before. Is that a true story?
Oh, yes.
Yes. And so I think what people hear about heart disease quite often, right? Eat your vegetables, rest, exercise, and pray you don't get it, right? And then we've added flavor to the conversation of being like, here's some really interesting genes you should probably look into because they really curate heart disease, right? Tonight, we're talking about two different populations, and I think one of the two is very unexpected, right? So let's kick things off. We're going to be talking about young people and heart disease, and then we're also going to be talking about people who have either had COVID or have long haul COVID, right? Somewhere in that happy little mess that is COVID. We're going to talk about the risk of heart disease following that. So, guys, why don't I start this conversation off first with this very agitating, fearful statistic. So, in the US, right, there's a lot of people that struggle with cardiovascular disease, heart disease. And typically, when you think of that person struggling with it, you think of an older person, right? Because that tends to be where it has situated. Yet we're seeing over the past decade and a half, those numbers increasing to the point where approximately there's a 21% increase in younger people with cardiovascular issues. In this instance, younger than 65, right? 65 is kind of when we start expecting this sort of thing and when we start screening for it. So anyone under 65 is considered pretty young. So why don't we wrap about that a little bit? So we're seeing it in younger populations.
Yeah, I'm sorry, Dr. Laura. I was going to say, I think that it's important to remember that the heart is a demand organ, right? And it just kind of gives you what you request of it. And it's not necessarily something that you can feel because it's very much controlled by the autonomic nervous system. So it's in the background and it's doing its job without necessarily our knowledge or us thinking about it all the time. But let's say that if you overtrain, well, if you work out your biceps, you feel it. You know when you've reached that tolerance limit. When it's fatigued, you feel the burn, quote unquote, and then you can put the weights down and stop. With the heart, it's just going to give you what your body requires of it, but you're not necessarily really in tune with what its demands are and how fatigued it's actually getting. So it's because of the autonomic nervous system component, I think that it tends to be a little bit of an afterthought until something shows up. Like, oh gosh, now there's all of a sudden a problem, but that problem may have stemmed from earlier on. And now it's all of a sudden showing up, but it was kind of accumulating throughout your life. Now we've introduced so many different toxic elements that I think that's a big part of why that goalpost has been kind of pulled back towards the younger generations. Dr. Laura, I cut you off. What were you going to say about that?
Oh, no. Actually, that's wonderful. And I love the information that you provide. Yeah, really, when it comes to cardiovascular disease, it comes down to inflammation. Honestly, the cardiovascular system, that is our main superhighway. That is how we get nutrients and proteins and other things from one place of the body to the next. And, that pressure allows that blood flow to get to the far little capillaries of our toes and our fingers. And it's very important. And when there is, and I'll use the analogy of that superhighway, when there's an accident or when there's traffic backed up, guess what? The goods and services, those nutrients, and those necessary hormones or whatever are not going to be getting to their end point anytime soon. And when there are blockages, that's when we have ischemia, that blockage of oxygen and nutrients to whatever part of the body that is being blocked. So it is so important that it is working well, that our heart has the power to pump that blood, to move it along, that the lungs are filtrating and exchanging those gases, the carbon dioxide and the oxygen. And it's all part of that beautiful system that really is just getting goods and services to where they need to go.
Yeah. Yeah. And I think to your point, right, it's not really, you don't necessarily feel the degrade of that goods and services not getting to where it goes. And I think Justin made a really, really interesting point. So us as clinicians, right, we see people, it's very difficult in my experience to motivate someone in their 40s or 50s, 30s even, to care about their heart health, right? Because to them, this is a risk that's pushed off so much in the future. And to Justin's point, you don't feel it. And so it's interesting as this creeps down into younger and younger ages, we're now saying, if the risk for heart attack really started in and around 60, 65, and we're now saying, maybe we need to start thinking about this at 50 or 40, how much more difficult it is going to be to get younger people who are still in the throes of my body works perfectly and I have no conception of my body not working well, right? Right. Because to your point, Laura, it does everything for us, but we're not necessarily feeling that until it's kicking our butt, right?
Right. Because a lot of it works into that chronic condition, just like Alzheimer's and diabetes and these other chronic conditions. Yeah. They take time to accumulate. I often refer to our toxic bucket. Okay. The normal toxins we are exposed to just through basic metabolic processes that, it's just like someone going out, getting groceries or having groceries delivered to their home. Yeah. They consume them and they have trash that has to be taken out. And that's normal metabolic waste that is being produced. But if that trash is not being taken out through the lymphatics, through the bloodstream and filtered through, liver and excreted poop, pee, all those Asian nations that Stephanie loves to quote, then we get buildup and it causes, that stinky trash and it increases inflammation and it just continues and continues. So if we're not emptying that bucket faster than it's being filled, pretty soon it's going to overflow. We are going to have overflowing trash. And that's when those physiological issues, those diseases become present. Not that they haven't always been there. It's just we are not actually aware of them as dramatically until all of a sudden, wham, we can't do something or we're really having some major problems. So we need to start being more embodied, to start paying attention to those little symptoms, those little changes, looking at blood work, having a baseline to know, hey, we're healthy, we're young. And like you were saying, Dr. Krista, a lot of the younger people go, oh, well, I'm fine, I don't need all this. But actually, that's when they should get that baseline of health. So later on, when they are having some issues, where was I before? They're their own N of one.
Well, let's dive into that a little bit of what you're speaking there. So what are medical researchers starting to attribute the why behind why these numbers are creeping down, why people in their 20s and 30s and 40s are having heart attacks or other cardiovascular instances? And let me be very clear, people in their 20s and 30s are having cardiovascular instances. right? Approximately 1.5% of cardiac events will happen, or cardiac deaths are going to happen in those populations. And those are removing kind of drug-related concerns. We're talking true cardiovascular events that are not associated to drug or something more traumatic than that, right? What are scientists, what are doctors kind of giving as to the why this is starting to happen in younger generations? Give me a little bit of texture to what is causing this inflammation and this lack of kind of the movement of the highways that you're talking about.
Well, a lot of it is because of toxic loads, more toxic exposures. It is putting pressure on their genetics that is causing inflammation on the cardiovascular lining, the endothelial lining, which is only a cell thick. And, when you start overloading the body, whether it be from, in the air, pollution in the air, whether it be from glyphosate or toxins in the food, or from, say, a virus that happens to have spike proteins that cause issues of the cells that create higher inflammation, that directly affect the endothelial lining, or even from vaccination, which is, the spike protein. And it doesn't really matter how you got it. The fact is that we virtually all have been exposed in some form or fashion. Either way, it really gets down to the fact that we are increasing the inflammatory response in our bodies, and it is affecting the endothelial lining of our cardiovascular, our arteries. And when there is higher inflammatory responses, when we get that microabrasions on our vascular lining, this works into the 9p21 gene locus, where you have a number and the letter G. Okay. So because it's not your typical, SNP, single nucleotide polymorphism, what it is we're looking at 3 different sections on each chromosome to see if you have a G allele. One of the analogies I like to tell my clients is that, keeping with the like a genetic street address that we're looking at, a gene locus is like a genetic street address. It's like driving down 2 parallel streets. And as you're driving down these 2 parallel streets, the chromosomes, for the 9p21 locus, we are looking at 3 locations on each. So 3 locations, 3 houses on each of these 2 streets. And we are looking to see if they have black shutters. So for every house that has black shutters, which means that the house can burn down more readily, you are more sensitive to inflammation. That as you're driving down, how many houses have black shutters? Well, if you have none, wonderful. That means that you're more of that stainless steel, arteries. You're not going to have many houses that burn down. You are not going to be so easily inflamed on the arterial lining. But if you're someone like me who has 5 houses out of the 6 that have black shutters, I can become inflamed much more readily in the presence of toxins in my bloodstream. And so what does that mean? Well, if I have more inflammation, that means that I am going to need an inflammation management tool. And I know I'm simplifying this a bit, but that's what cholesterol does. It acts as that inflammation management tool. So the more inflammation I have on my cardiovascular lining, the more cholesterol will be needed, because it's not like we can go in there and throw on some salve and throw a Band-Aid on it. Can't do that. So our body does this for us. The only thing is that the more inflammation I have, the more cholesterol I'll need, which would result in higher cholesterol numbers. But cholesterol cannot travel through the bloodstream on its own. It needs to have a taxi. Well, this is where our LDLs, low density lipoproteins, and our HDLs, our high density lipoproteins, come in. They are the taxis. So if we need more cholesterol, guess what? We're going to need more taxis. Well, that means our LDL levels are going to be higher. And we need to be careful not to focus on the taxis and the cholesterol. We need to focus on, why do we need them in the first place? what is causing the inflammation? So that's when we have to cycle back and go, hey, what are you being exposed to? Whether it is, you know, some, you know, smoke, like look at the wildfires that were happening in Southern California a couple months ago, all that soot and smoke and everything else, the toxins that were in the air that we're breathing in and that it's affecting our lungs, you know, the foods that we eat, you know, through our own genes, a higher risk of having, you know, inflammatory metabolites being made, or through, say, getting COVID or a COVID vaccine.
Yeah. And I would also, and I wonder, Justin, if you can explore this a little bit, I'd also just simply say, while our world, we all agree, is dirtier now, right? We have fires, we have glycophosphates, we have weird things in our soil and on our plants, right? We also know, and while arguably root cause might be the same, we also have incredible rates of obesity. We have incredible rates of diabetes, right? We already know that the screening guidelines for diabetes have dropped from 50 down to 40 because young folk are getting it so quickly, right? So let's talk about even the basics of sleep, right? We as younger generations aren't sleeping anymore. So all of these are kind of individual insults, but let's talk to how it's kind of this death by 1,000 cuts. Justin, talk to us about lifestyle. Talk to us about things that young folk are doing that are ticking off the ticker.
Yeah, and there's likely quite a few things that are being done nowadays that wouldn't have been done by our ancestors or up until pretty recently, right? Like 100 years ago, even lifestyle variables are quite different. And it's got far-reaching implications, right? Because if I were to pose it to everybody here like this, where does your cardiovascular system begin and end? Right? Where does your nervous system begin and end? Well, everything leads into the next system. So I think we all understand nutrients. We all understand hormones. Well, what do you think delivers all that stuff to the farther reaches of your body? It's your vascular system, right? It's your bloodstream. So if we have a kink in that hose, then there's no telling how many different areas that's going to actually impact with regard to inflammation, immune activity, all of the above. I think that the younger generation now is definitely got the most working against them than any generation really has, right? Because to Dr. Laura's point, I mean, you know, we have gigantic wildfires where we get all these extra oxidative radicals in our bodies. The food quality, you know, that in and of itself, I believe, is a constant source of inflammation for a lot of people because the body just doesn't recognize it the way it used to. The body knows what food is and the body knows what toxins are. And when we eat something thinking it's food, but it's actually toxins, of course, there's going to be the subsequent immune response, right? There's going to be these immunoglobulins like IgG that get increased in the body. And it's just this microinflammation that's constant. So that's very taxing on the cardiovascular system. I think that Wi-Fi, I think that toxic media, I think that even just stress, you know, and this is kind of an area that I talk about with regard to the pandemic, because people like to strip it all the way down to only vaccination status and only illness status. Did you get COVID? Yes or no? Did you get vaccinated? Yes or no? But a broader category here is the stress all of us went through. Like, what did we just go through? Can anybody even tell me now what we just went through? It was a really confusing time for a lot of people, difficult on people's businesses, people's finances. I can't imagine what it was like being a kid going to school and having to separate from all your school chums and put hand sanitizer on every time you enter the building and wear a mask the entire time. The stress alone of the pandemic, I think, had a lot of nervous system disruption. And that, coupled with spike proteins, was likely a big contributor to people's cardiovascular issues.
I like that. I like that you wrap stress into that, right? Because I think I know Dr. Varden, this is a passion of yours, but as we chase down very physical things within the body, we're forgetting probably arguably the biggest causer of cardiovascular disease. And we know that rates of anxiety, et cetera, are quite high in younger generations. I think it's an interesting question, is that because they can better identify and they talk about it more, whether it's truly an increase, that's, you know, different questions. But regardless, we know that there's high instances of anxiety and other stress-related mental health conditions. Yeah.
And that can really create a downward spiral when you're talking about stress begetting stress. that stress is affecting sleep, you know, and there are several genes, you know, if someone has weaker genes when it comes to stress in BDNF, their clock gene, TPH2, their 5T, HTT-LPR, you know, all of these genes, if they are dysregulated in any of them, that ends up being a weak part of that dam that, you know, ends up being affected. And then if they're not getting good sleep, their body is being more stressed. And then again, it is this just downward spiral. And it's really hard to get out of it, especially, you know, like you had said, Justin, that, you know, how we were set in the pandemic, people were separated from their own families, that, you know, there was such a social separation. We are social creatures. The amount of oxytocin and dopamine you get just from a simple hug is unbelievable and necessary. And that a lot of that stopped. A lot of that, you know, was not allowed. And to not have that for so many years, that in itself can cause stress. So it's not just the emotional, but there's the physical, chemical, all of these stresses that were just compounded. So, I mean, it's kind of like, no wonder.
Yeah, I want to transition into the next group that we're talking about. But before I do that, I wonder if the powers that be can offer up the survey questions. So if you're a new offender on this webinar, we love to ask survey questions, because our goal when we show up to speak with you is to ensure you're served, that what you're curious to learn about, we are speaking to you. So if the powers that be want to pop up the survey, please. Do a dance interlude until we get there. Maybe not. All right. Okay, cool. We're going to be dynamic. We're going to jump into it. We're going to get that survey up, I promise. We're having some technical difficulties there. Oh,
there we go.
As soon as you say technical difficulties,
there
the
it is.
like, not anymore. All right. So the first question we asked is, do you have a history? Actually, hold on. I'm going to go last question first and then jump back at the top. I want to know how old people are here today. So we're talking about, I love this, about 35% of our audience is over 70. Welcome, hello. We're grateful that you're here learning about yourselves and your health, and then learning about those that you care about. An equal percentage, 35, is in their 60s. We have a quarter in their 45 to 60. And then we have a strong 5% that's under 45. Welcome and hello. We're so glad you're here. This is, especially the first half, is really dedicated to you, but the second half as well. We asked the question of, do you have a family or a family history of heart disease? And 50% say that they have a parent or a sibling. I'm surprised by that. Usually I see that number a little bit higher. I don't know the actual epidemiologic data, but I would have expected that to be higher. So I'm glad that our audience has a healthy family history, relatively speaking. 24% is saying they have extended members with such, and a blessed 20% is saying they have no known family history, and then 7% is saying they're not sure. The next question we asked, have you ever experienced a cardiovascular concern? A quarter of our audience has been diagnosed with something. 15% of our audience has experienced something, but not necessarily diagnosed. And a beautiful 50% has said no, but they're looking to the end of prevention. 10% is also here for their family as well. I'm always grateful when people come to learn and support others. From a perspective of who's in the audience, about 75% this evening are female, with 25% as male. All right, so let's jump into this next conversation where we are talking about having a COVID infection, which I don't know the statistics on this, but I think reported it's quite a frequent thing, you know, over the past 5 years, someone having been infected by COVID at least once. We know that having an experience with COVID in particular, a more marked, right? We're not talking the asymptomatic, but the symptomatic, the presentation COVIDs, increase risk of cardiovascular issue by 63% in the subsequent years, right? Remember, COVID's only 5 years old. It's a little bit difficult to say that it's approximately 5 years old, so we don't have longitudinal data on it yet, but we do know that having been infected for at least definitely the year, likely 2 to 3 at least, right? No, right now, increases the risk of cardiovascular disease. Let's talk about that. That's huge because most people in the world have had COVID.
Yeah, and I think that it's really something that, like Dr. Varden talked about toxic load. And I really wish everyone in the world would have their genes done prior to these pandemics happening so that we could know who was the most predisposed
Prior to a pandemic, just pandemic prevention.
Yeah, next pandemic, let's make sure everybody has their genes so that we can at least kind of extrapolate a little bit better. Because I suspect that a lot of the people that had the worst symptoms and the worst time in general with COVID are the ones that already had some level of genetic predisposition to not be able to deal with the cytokine storm very well. And that could be stemming from like suboptimal vitamin D genetics, suboptimal methylation, suboptimal detox genetics. It's a cumulative thing, right? Like if we have a lot of inflammation going into getting COVID, it makes sense that the body has difficulty sort of prioritizing what to deal with first. And I think long haul COVID is going to be that much more likely if you already have some sort of underlying genetic issue there with the dealing of inflammation, right? So it's a little bit more complicated of a conversation than people I think like to make it. It's really got a lot to do with how well are you metabolically speaking first. And a lot of people nowadays we know are just metabolically unhealthy. And then you get COVID. Well, of course, you're going to have a much harder time with it. Dr. Varden, what do you think about that? Because you're a super genius.
No, far from.
We should make a little hat that says super genius.
I'm just extremely curious. No, actually, during the pandemic and as it aged some and they were finding people who were hospitalized, those people that were hospitalized as compared to those people not, or that had some, but they recovered more quickly. The difference was comorbidities. Those people hospitalized ended up having multiple comorbidities. They also had looked at vitamin D levels. They looked at, trying to remember because it's been a little bit since I've read some of those studies. I do remember that the vitamin D levels that they were looking at was that people with vitamin D levels of 50 nanograms per milliliter or higher were much less likely to be hospitalized. But again, the more comorbidities someone had, meaning disease states, like say they were diabetic or they had, pre-existing heart issues or whatever, the more that they had, the more likely that they were detrimentally impacted by getting COVID. So that was a major thing. I mean, really, this underlies, like, actually someone had said, I remember seeing in the chat about Angelina. She said, it's imperative to take good care of ourselves. Absolutely. We've got to have a good, strong terrain, making sure our soil is fortified so that way our tree is nice and strong and can handle whatever storms come through.
Yeah.
Very important.
No, I agree. And I think, again, the difficulty we have when we talk about cardiovascular wellness, or even, going into such a horrible event as, acquiring something like COVID, it's really difficult, I think, mentally for sometimes people to get to the end of, I must prevent, or I must do what I can now today in order to prevent that event tomorrow. Because humans weren't necessarily built in the way that they think to tomorrow. They're kind of thinking they're lost in their today. And so the idea of how do I build up my terrain so that when I encounter these sorts of things, right? And that's difficult. I think that might be the crux to a certain extent of it. How do we separate ourselves from today so that we're thinking from a health perspective of tomorrow?
And that really separates the sick care model to the healthcare model.
Yeah.
Seriously, because it's like we are just so used to only really paying attention and taking care of ourselves when something goes catastrophically wrong, or when something is falling apart, when our wheels are falling off and rolling away. It's just like, oh, maybe now I should do something about that, when actually we need to start young. We need to make sure that we are making the good decisions in lifestyle, in food, in sleep, in learning techniques on how to deal with stress, etc. So that way the wheels don't fall off in the first place.
Yeah. Mary is asking a question in the chat that I really like, and she's effectively saying, you know, I've had my genes done. How do I know how to make best use of them? And I think, Laura, this gets to your idea of preventative medicine models, right? In the sense of, once you know your genes, everyone's genes are obviously different. There's going to be trends. Some people are going to be weak when it comes to cardiovascular. Some people are going to be weak when it comes to detox, right? And managing all the inflammation, right? And so both of those equations, right, you have to approach them differently. So Mary, I mean this plainly in that the plan we'd offer you would be very different than the plan we would offer someone else. And it takes that working with a practitioner to understand not only the genes, but what you're willing to do as well. And I think this is where that personalized medicine model comes in, because the conventional medicine model at present, unfortunately, is not set up for that. They're set up for the reaction, whereas the model we're trying to shift into is the let's gather all the data so we know how you are right now and are designed to be, right? And then create a plan that, you know, plan that you execute every day as to how do you go about preventing, because everyone's prevention plan is different.
Yeah, well, and the self-care model is very much opt-in, right? Whereas the sick care model is you end up being forced into it. So it's like you can either opt in now or be forced in later. And you know, to her question there, it really could be any number of things. Like there's no one gene that's of relevance. I'm of the opinion that all of them matter, because all of them are going to impact how your body functions, right? Like that's why we arrived at the ones that we arrived at. Like let's say we have a gene called SLC23A1, which has to do with vitamin C transport. Maybe you have a suboptimal version of that. And for that person, it's going to be a lot more important that we purposefully include vitamin C in their healthcare plan. Everybody else is just going, oh, I heard vitamin C is good, so it's probably a good idea for me to take it. And you end up with this massive cabinet full of supplements because you heard and you heard and you heard. Right? So we need to go ahead and prioritize and personalize. And that's why we teach this self-care model. And there isn't one gene in the DNA 360 that doesn't have some level of direct or indirect influence over how the body's going to function and therefore deal with something like COVID. And then we have a specific cardiovascular report as well, right? So that matters a lot for this conversation. Every gene there is of relevance for how your system works.
All right. So why don't we dig a little bit into the vaccine? Does that impact cardiovascular health?
In my opinion, yes, it does. I do believe that both the vaccine as well as the infection have had detrimental effects on people's cardiovascular health. Like I mentioned before, I believe it's in combination with nervous system dysregulation due to the sheer stress of the pandemic. I think all of it together is certainly didn't do anyone any good. I don't have a ton of statistics to reference here, but in my own practice, I've definitely seen a rise in people having just the symptoms, right? Like shortness of breath and things that we kind of correlate to cardiovascular issues. So yeah, I think that both the vaccine and COVID itself have had a pretty detrimental effect. Ladies, what do you think?
Well, when you start thinking and recognizing the mechanism of action of how the SARS-CoV-2 virus itself enters a host cell, okay? It is through the angiotensin converting enzyme, ACE2 receptor. That is really abundantly expressed in heart tissue, okay? So when you had the virus actually contains 4 structural proteins. You have the S, the spike protein, the envelope, the membrane, and the nucleocapsid. And it's the S protein, that spike protein, that actually was leveraged and used for the vaccine itself. That happened to be the toxic part of the virus, but so be it. Let's just stick to the facts here as far as like that S protein, that spike protein, that helps to mediate by helping that viral particle to enter the cells. So after SARS-CoV-2 downregulates that ACE2 expression by attaching to that receptor, okay, it prevents the enzyme from actually exerting its normal cardioprotective effects. And there is that disruption in that renin, angiotensin, aldosterone system. It's called the RAS system, RAAS, and that contributes to cardiovascular dysfunction and therefore injury. So that's one aspect of the mechanism, the mechanistic damage that the spike protein itself does to heart tissue, since we are focusing on cardiovascular. I mean, obviously it affects other, tissues and everything else, but we're staying a little focused here. But we cannot forget the fact, I'm still going to come back to the inflammatory cascade, that cytokine storm that happens, because that is a very defining feature of severe COVID-19. That cytokine release, it actually is characterized by hyperinflammation. And that elevated inflammatory markers that can be measured. And that's what, one of the things that were measured. And that increases the levels of these other inflammatory markers like interleukin 6, IL-6, or C-reactive protein, ferritin, and other cytokines that contribute to that myocardial oxygen consumption, the endothelial dysfunction that I was talking about earlier. All of that suppresses, that lessens the functionality of the heart itself. And like I had mentioned before, inflammation, that really is the basis of the majority of chronic conditions and diseases.
Yeah. I think the tricky of it is, we're only 5 years out and, arguably 4-ish from the vaccine, right? And so I think we concretely know a few things. I think we concretely know that when people were receiving, in particular, younger males were receiving, they were the biggest at-risk group, right? When they were receiving the vaccine, out of every 1,000,000 cases, about 200 would develop a myocarditis, right? And what that means is the heart muscle becomes inflamed. And because it's inflamed, you think about it swelling, it's not going to pump as properly. So some of these men or boys to men, depending on where the age range was, they may present, this usually happened within 2 weeks. And they would present sometimes to hospital or to doctors saying, I'm having shortness of breath, something in my chest is funky. And a majority of those, 80%, recovered and were okay within 2 weeks, give or take. Approximately 20% did need ICU care, and then there were a few more extreme cases. So we know that for every 1,000,000 vaccines given, there was 200 events. Now, what we don't know is what the longitudinal wellness of these men are going to be. We don't know what that looks like 5, 10, 15 years from now. If they had this, what does that impact on their heart health? Did they truly fully recover? Did they not? Right? What we also know is that those who have received the vaccine, if they contracted COVID, it was a lesser form, so a lesser cytokine storm, amongst other things, as well as a lesser risk of developing long-haul COVID. And we know that long-haul COVID, simply based on its incredible presentation of inflammation, et cetera, right, will increase risk of cardiovascular illness. So I don't know if science is at a point yet where we can say yes or no. Right now, I think it's tending a little bit more towards it, by and large, is protective. That said, that doesn't mean at the individual level it's the right choice. I think this is where conversations with doctors become all the more important, right? Because if you have certain family histories of this, that, or the third, maybe the vaccine's contraindicated for you. Whereas if you don't, maybe it's not, right? Like this is kind of where, when you're playing with big numbers and big statistics, you can't necessarily drill down to the individual. That's that conversation that has to happen between provider and patient, right? That's really important. That's the je ne sais quoi of personalized medicine, that one-to-one conversation. Justin, I see you itching. Let's hear it.
Wow. Yeah. So just, I wanted to say where I believe the problem lies is when the stripping of people's autonomy to make that very decision came in, right? To your point,
Million
there's
percent
a
agree.
lot of moving factors as to how your body's going to deal with different things. It doesn't make you an anti-vaxxer if you had some questions about it prior to literally injecting your body with something because the government was telling you to inject your body with something. It's okay to be curious and it's okay to have questions. And maybe
It's
I thought this
important to be curious
vaccine
and
was
have
good.
questions.
Right. Questions. That's what science is, right? We question things and nothing is a one and done. To me, there was overstepping that took place. And the more overstepping that took place, the more I went, there's something that I don't like about this. And so I personally chose not to take one. My lady got fired from her job. She had 7 years seniority where she worked, and we have a child with special needs. And her source of income was cut off because she chose not to take the COVID vaccine. To me, that added to cumulative stress load. And to me, that didn't do anyone any good. The government was saying over and over again, safe and effective, safe and effective, safe and effective. Well, it turned out to be less effective than we thought. And it turned out to be a little less safe than we thought. And to me, that's not okay. Whether or not you chose to take it, to me, that should be an intimate conversation between you and your provider who knows everything about you, hopefully including your genes. And that's the problem that I had with it, was the overstepping and the stripping of someone's autonomy to make any medical decision, to me, is not okay on the government's part. That being said, I think some people likely benefited from taking it. I think some people likely took it and had some negative effects as well. So, as with everything, it's a nuanced conversation, but I think that it really should be a pretty personal decision that the government shouldn't be allowed to step in and force on anyone.
Yeah. I think the pandemic, one of the biggest things that highlighted to me, there are many things, the biggest thing it highlighted to me was the lack of nuanced conversation in public forums about science. Because when it comes to vaccine, there's saying it's absolutely right or absolutely wrong is categorically wrong, right? You have to sit in those shades of gray. And I think it does not do science and doctors a service when we do not enable and empower that conversation, because then we're feeding into this idea of it must be yes or no when we already know it's a question of gray. Yeah. Dr. Varnon, I see a thought percolating.
Yeah, well, it really comes down to taking back your own agency, and knowing yourself, and having that medical freedom to make the choices of what happens with your body. But you need to be informed. I mean, granted, we can't be all PhDs and understand all the complex science, but doing your due diligence on things that are most important for you, especially when it comes to your health, then take that time, educate yourself or go to someone who does understand, who can explain it better and get a full story. But to have things be redacted or, oh, we can't talk about that. It's health. We should not politicize health. It is what it is. And, knowing your genes is one of, I think, a very important factor into knowing where your weakness is, where are your strengths. And that way you can better navigate making decisions on what you will expose your body to and how that will work and what you need to do to support your body in case you are exposed outside of your own control. So, I mean, that is really, really important.
Yeah. I would love to recount for the audience an experience I had with my GP, which I wish I could have recorded and shared with people, because I thought it was a very good example of how practitioner and patient to an extent should be collaborators in health. So I went to her and I said, hey, I'm thinking about this. You know, here's what I've read. I want you to tell me where my gaps are. What have I not considered? Where are my biases? Right. And she went through and she listened to what I had to say about it. And this was, you know, early days. I think the vaccine had been out a month or two at that point in time. And she said, no, you're pretty on point. This is more or less what we know. And I said, okay, what I've heard through the grapevine is this. And I was very specific to female data because I'm a female, I'm a menstruating woman. And I said, I have heard that the vaccine is disrupting women's cycles, right? And we only had a few months data of that. So like the fact that there is disruption, we didn't know how long, we didn't know how significant. I was like, I'm reading case reports. There's no large data on this yet. But we also know that when, you know, women aren't well studied in studies to begin with, but when you're pushing something through, tracking menstrual cycles is not necessarily going to be top priority. That level of data may not have been there. And so she said, interesting, okay. And so she took it back and she did her own research and she's like, I'm seeing case reports, but I don't know how to counsel you because we don't have enough data yet. And I thought that interaction with her, me coming and saying, help me understand this, and her hearing me out, and then separate to that being like, you raise a good point, let me do research, was probably like, she went over and above. We have a very good relationship, but it was still that engagement of, let's examine where the truth sits and let's not dismiss you because this is so new. You know, if we're talking the first few months of release, she was honest about not having necessarily the data to make informed decisions. And again, I wish I could have recorded that because I want people to learn from that experience of when you have a doctor, those are the sorts of conversations you should be having. And if they're not willing to have a conversation based in fact, perhaps you need to have a conversation with a different provider that is going to give you both sides of the story, right? You don't want one. You don't want a provider that is confirming your bias. You want a provider that's able to say, here's the extremes. Let's talk about the gray.
I wanted to share a little bit of my story with it simply because this is reflective. Now, granted, I was, you know, getting my PhD at the time, but reflective about doing the research and understanding. So, for example, I have had Bell's palsy 3 times. Okay, this is before the pandemic. First time was in 2007, then it was 2016, then it was 2018. I didn't like it, didn't want it again. And one of the side effects that was listed on the shots was Bell's palsy. So that was a big red flag to me. Also, I have a history of having lower limb thrombosis when I was pregnant. And that does happen with hormones in pregnancy and things like that. So I genetically have a predisposition in that. And because it had been found that between, you know, having the virus or the vaccine, that there was side effects of thrombocytopenia. That was not something that I was willing to take the risk of. Now, again, I knew my history and I looked up the research because I looked at Pfizer's, Moderna's, I looked at their research that they had done in their trials, and they have to list what are side effects that they had seen. So I brought that to my doctor. I said, hey, listen, I'm really not comfortable doing this. My university says that I need to get it, but I'm really not comfortable with it. Can you write me, look over the paperwork, and if you agree, can you write me a medical exemption for taking the COVID shots? And he's like, sure. So he looked it over and he said, yep, this looks sound, reasonable. And then he wrote that to me and I submitted it to my university, and thankfully they accepted it, and I didn't have to deal with any issues on, losing a job or not being able to finish my PhD at the time. So the point being is that know your rights, look it up. I didn't need to be a PhD to do that. Okay. Yeah, I happen to have the higher sciences to have a better understanding, but still take your agency back. And again, I saw about, hey, cardiovascular and things. This is very important because this is directly impacting your medical decisions on what is going into your body. and the inflammation and the direct effect it can have on your cardiovascular system. So, like I had said, with thrombocytopenia and all honestly, one of the other things is hypercoagulability, where it's basically platelets and other uh, okay, thank you.
Yeah.
Having
words.
clots, there we go, simple words, clots, okay,
Yeah.
that tend to grow, and you know that actually is a something that they have found, these microclots that end up blocking, like I had said in the beginning, your streets, your roads. You can't get the goods and services, you can't get the oxygen and the nutrients to these limbs because of the microclots that end up building up. And you know, there are tests, D-dimer test actually is something that you can take to find out if you have, you know, clotting happening in your body, these microclots. So yeah, this is important to know what can happen.
Yeah. So I want to circle back now to the Q&A, which I think will focus on heart disease and cardiovascular. But I like that idea of autonomy, especially to the end of not even just vaccines, but autonomy when it comes to food choices and autonomy when it comes to sleep choices. Because I think we become so entrenched in the flow of life that the flow of life takes away a lot of our health just simply by not sleeping enough, not eating properly, not breathing enough, and not all the things, right? All right, so question time. Cheryl has a question for us. She's asking, what is the purpose or recommendation for Cardio Miracle? So I guess Cheryl's been on our webinars before where we've talked about Cardio Miracle in relation to cardiovascular wellness. Would either of you like to field this? You let me know.
I'll take this one because that's one of my favorite friggin' things that I take daily. Cardio Miracle is, if you're not familiar with it, it's a supplement. It comes in powder form, and it's pretty unique in that it's not just an anti-inflammatory supplement, right? Like it's not just a combination of fish oil and turmeric and things like that, all of which have their place and their use. Cardio Miracle has got a combo of blood flow agents first. So it's got this complex spectrum of different things that dilate your blood vessels by creating nitric oxide. It's the only product I'm familiar with that actually creates nitric oxide for a full 12 hours per dose. Generally, if you use like an arginine, a citrulline, agmatine sulfate, it's going to do it for 3 or 4 hours, and that's why people use those products acutely prior to a workout, right? Because you can get better blood flow during your workout, and that's great. Nitric oxide has so many benefits in the body that this product was like, why don't we do it so that it actually delivers nitric oxide for a full 24 hours? So it does 12 hours per dose. You dose it twice a day, and it gives you a full day worth of additional nitric oxide with a blend that actually does it synergistically. Then they added in all of these different botanicals and these anti-inflammatory agents that are meant to actually heal the lining of the endothelium. So Dr. Laura was talking about the 9p21. It's a chromosomal locus. And if you have the higher Gs, like 3 or above, you're at a lot greater risk for having the damage associated with inflammation in the endothelium. The CEO of Cardio Miracle had a 6G, right? So he actually did his DNA with us way back in the day with Dr. Mansour Mohammed, and he's got that really thin endothelium. So he created Cardio Miracle effectively to scratch his own itch there. So it dilates your blood vessels. It gives you all this great blood flow. And then it has all this astaxanthin and grapeseed extract, all of these nutrients that are really designed to heal that endothelium that may be damaged due to inflammation. So it's a blood flow agent, and then you get anti-inflammatory and healing nutrients being delivered all over your endothelium 24 hours a day. It also helps with things like internally stored vitamin D. That's a little known benefit of nitric oxide, that your body actually stores it in adipose tissue, and nitric oxide comes along and helps to release it so your body can use it. So I also recommend it for people that have suboptimal vitamin D profiles as well, because you can use more of your own vitamin D that way. So great for anybody that has any kind of cardiovascular issue. I think it's the best product on the market for that.
Our next question comes from Leslie, and she's asking, what is the best measure of cardiac inflammation? I have a thought, and you may not like it, Leslie, but I mean this sincerely. Whenever I see a patient or a client, I do a bit of a history before I run panels. And from my perspective, at least, there's different levels of panels that you can do for cardiac inflammation and heart wellness. And so that initial intake will really gauge how deep down the rabbit hole we go. Because you get really good parameters out of basic blood work, especially Dr. Varn talked about cholesterol and how that can be a big reflector of inflammation within the cardiovascular system or body in general. But there's quite a few panels. I love one out of Boston University that dives really deep into the specific metabolites of different lipids and of different proteins and of different enzymes within. And so I think it depends on your heart history as to what rabbit hole you go down to really dig in there. And I know that's a general answer, but Leslie, I say this to the end of, this is where personalized medicine comes in, right? This idea that there's, short of maybe intake in that first panel run, there's a huge element of personalization that should take place for everyone's wellness care. Yeah. Laura, Justin, any other thoughts, anything that I missed, any favorites that you'd want mentioned there?
You nailed it.
Yeah, I mean, again, a lot of it has to do with inflammatory markers, whether direct or indirect. But again, it's not like you have to go out and pay a lot of money to have all these markers. I mean, do something that it's actually actionable. Well, it's like, when you have this information, what are you going to do about it? So, and that's where a practitioner.
Paralysis. And that's where Justin of the world comes in. I adore Justin because he's like, stop thinking, go do.
All action solves all. That's the truth.
Yeah. All right, Leslie has another question for us as well. Does exercise play a role in reducing inflammation in the endothelial lining? The answer is yes and no. Who would like to explain the yes and who would like to explain the no?
Yeah, that is like that double-edged sword. And again, looking at your genes can determine where that line is. Because absolutely it can be beneficial in the fact that exercise increases nitric oxide production, like what Justin was saying about Cardio Miracle. What does nitric oxide do? Well, it helps to vasodilate the blood vessels, for lowering the blood pressure, for, lots of different things. It helps to improve those levels. It, reduces the arterial stiffness. Okay, better blood flow. It also helps to lower inflammatory markers. Remember I threw out a bunch of inflammatory markers mentioning them. And when you are able to lower those inflammatory markers that can contribute to oxidative damage of those blood vessels, well, then all the better. Remember, number one thing is to mitigate the exposure of the toxins, okay? And oxygen, reactive oxygen species, these oxidative molecules are what are causing damage. I mean, there are several different things when it comes to methylation, because exercise helps to lower homocysteine levels. Remember, I had mentioned about homocysteine being a marker of systemic inflammation. It helps with insulin sensitivity, reducing those blood sugar spikes, because high blood sugar damages the endothelial lining. That leads to inflammation. Remember, we always get back to inflammation, darn it. So, it really helps with that. It helps to promote autophagy, cellular repair. Okay. So we want to get rid of those old, worn out, cells and the damaged cells. But here's the thing. This is the other side of the line, is that if you exercise too much, if you do not give your body the time for rest and repair, it's kind of like having a beautiful car, any kind of car, driving it, but you take care of it, you give it gas, you give it oil, you let it sit in the garage and give it a rest. But on that flip side, when you are over exercising, that's like driving that car with the pedal to the metal all the time. You're not putting in more gas. You are not stopping, to change the oil. You are letting it overheat. Guess what's going to happen? Yeah, that engine is going to blow. You are going to have wheels falling off and going everywhere. You're going to damage that vehicle, your body. So it is that balance between getting the hormetic beneficial effects from it, but not overdoing it where you are actually further damaging the cells, the tissues, the organs, the body.
I'm going to add in a fun factoid between this question and the next question, because Justin, the next question is coming to you and I know where you're going to go with it. Exercise is shown, especially if you do it consistently, it will have positive changes within your gut biome. And your gut biome is a huge curator of inflammation in the immune system. So simple exercise, additional to everything that Dr. Barton just said, will change the little critters that live in your gut and everywhere else in your body. And then that will also reduce inflammation within the body. Segue. Dirk. Hi, Dirk. It's good to see you back. We haven't seen you in a while. Dirk is asking, to what extent is the inflammation from gum disease, so we're talking within the mouth, higher risk of, gum disease, higher risk for heart disease than inflammation from other parts of the body, and why? Justin, do you want to explain why our gums and why dentists are so important to our ticker?
Yes, because the mouth is in fact a microbiome. I love that Dr. K just knew exactly where I was going to go with this right off the bat. So like, for example, like chewing tobacco, right? Which is kind of a gross thing that some people I know still actually do. The reason it works is because when you put something in your mouth and it gets up under your teeth and in your gums, it enters your bloodstream, right? So that's why the nicotine has an effect, because it gets into your bloodstream through your mouth. So bacteria can do the same thing. It can, if there's dysbiosis in your mouth, which is effectively what gum disease stems from, then that bacteria, that bad bacteria, is also going to work its way into your bloodstream and become systemic. It's entered circulation now, right? So that's going to be an effectively contributor to inflammation. As to the real extent of it, as opposed to other areas of your body, I'm not sure if that science has really entirely been hashed out. That's just the way the question was worded there. But I'm actually of the opinion that it's a relatively significant contributor. I think a lot of people are walking around with dysbiosis in their mouth, and it does cause issues at the level of the cardiovascular system, So I'm a big fan of taking care of your mouth. It's the first stage of digestion. It really has its own bacterial balance, and we want to make sure that we pay respect to that, not going too crazy with antibacterial mouthwashes and things like that. We all know that I love, Ayurvedic medicine for this, tongue scraping, coconut oil pulling, essential oils, and these kinds of things. Red light therapy for the mouth is great. I mean, you can do a lot of things to correct that bacterial load if you do have gum disease. But yeah, to answer your question, I do think it's a contributor for sure.
Another fun factoid, just to kind of tie it back to your cardio miracle conversation. So the bacteria in your mouth, they don't serve just to the end of providing balance, etc. They also help with digestion, pre-digestion. They send messages down. As they come down, they support food, and they're actually good bacterial balance. You need certain colonies, but that will contribute to nitric oxide production within the body. All right. Nina has our next question. Nina's asking, is it true that in a case of COVID, we should drink pineapple, brackets prevents clotting, and turmeric, anti-inflammatory? So I would imagine you're talking about an acute case, not necessarily the long haul. I have thoughts. Does anyone else have some thoughts?
Yeah, actually, we had mentioned this. I had mentioned this the other night when we talked about long COVID on our webinar. And actually, the two particular compounds that she's referring to in pineapple, it's the bromelain. This is a natural anticoagulant and anti-inflammatory. It actually contains a proteolytic enzyme. Proteolytic means that it will break up proteins, and it breaks down fibrin. Fibrin is forms clots. Okay, when there's injury, then you have that enzyme thrombin, which converts to fibrinogen, and then it makes these fibrin strands. Okay, remember how I mentioned earlier about the clotting that can happen with the spike protein? Well, so in bromelain, it helps to break that down. So it's breaking down those clots that are forming. And it also helps to reduce blood viscosity, meaning the thickness. It makes it thinner, helps to improve circulation, acting as an anti-inflammatory because it decreases pro-inflammatory cytokines like IL-6 that I had mentioned earlier and TNF alpha. It's also very rich in vitamin C and manganese that supports immune function, and that oxidative stress, it helps to reduce that. The other one that she was talking about in turmeric, the compound is curcumin. This is a very potent anti-inflammatory antioxidant, helping to reduce that cytokine storm I had mentioned earlier, lowering those inflammatory cytokines like IL-6, TNF alpha, NF kappa beta. It also helps to support the endothelial lining by reducing clot risk, boosts nitric oxide production. So, when you consider the wonderful benefits that these have and the foods that they come from, I mean, they're good not just in an acute situation specifically of COVID, but for long COVID and for any other type of inflammatory process.
Yeah. If you're struggling with long haul COVID, we're setting up a program where we can support and see people to the resolution of that. So keep your eyes on your mailbox, because we know a lot of people out there struggling with it right now. My next question is from David, but in the interim, Jason, you've asked a question and I don't really have much context as to the question. So if you want to re-enter it, that would be very helpful, because I don't know how to, I'm not entirely sure what you're getting at. David has asked a question, and I love this question. Why is gene work better than blood work analysis? Who would like to jump into that one? I can if no one wants to, but
I have a quick opinion on it, and then I'll let you take it over.
you're going to say what I'm thinking. You're good.
Yeah, I don't think it is better or worse. I think that they both have a place, and they're quite different metrics that you're looking at. Genes really represent baseline tendencies of the cells, how the cells behave, right? I mean, so many things in the body operate because of enzyme activity. Enzymes do all the stuff, and genes encode enzymes. So when you have a gene telling an enzyme to operate at this speed, for example, that's going to be the default setting, and it's going to have cellular effects. Your cells are going to operate based on how the gene told it to. Right. So that's a really important thing to look at. But blood work is like, what's going on right now? Because we know that there's methylation patterns. We know that the body has also got epigenetics to consider. And your epigenetics, based on your lifestyle behaviors, is going to impact things like a C-reactor protein and HbA1c, et cetera. So I think that the genes do one thing and the blood work does another thing. And I don't think it's a question of superiority of one versus the other. I actually think they're great in tandem, but you need to know your genes to understand the baseline tendencies, and it's less talked about than blood work. So that's why we don't shut up about functional genomics. That's what we do. Dr. K, I'd love to hear what you have to say.
No, you clocked it, you nailed it. I loved it. I have no notes. That was perfect. Yeah, I think it's important to work with a practitioner who knows all sides of it, right? That's where the guidance can be, because I can appreciate there's so much testing that can be done. There's so much data you can collect. Working with someone who will help guide what's important to what you're seeking to do within your body, that's very important. All right. So Tisha, I hope I'm saying that right. Tisha's asking two questions, and I think we saw you on the other night. She's asking around the end of how do we lower inflammation in general, because we're talking about heart disease. How do we keep that inflammation low? She's also how do you detox spike proteins? And Tisha, I would direct you back, and maybe the powers that be can toss this in the chat. We did a webinar really on long haul COVID, and there's a lot of thoughts around not necessarily specifically calling out spike proteins, but more the recovery of COVID and long haul COVID. So I would defer to that. But why don't we Justin and Laura, there's no way that we can offer how do you lower inflammation. Why don't you pick your favorite way, the favorite thing that you wish patients would pick up to reduce inflammation? Why don't we give them kind of one of each of our favorites here?
Everyone knows I'm going to say grounding, so I might as well just say it. Yeah, like anything that's really simple and cost effective, which is effectively zero in this case. The body's very electrical, and until you touch the ground, you're accumulating positive ions, and it's going to change the way that your cells work and make it a pro-inflammatory state. Take off your shoes and socks, walk on your lawn, and that's a baseline tendency that I have, at least from April to October, until the snow hits. What about you, Dr. Laura?
Well, one of the things that I like leaning into is your foods. Pay attention to your foods that you are putting in your mouth. Really work toward an anti-inflammatory diet. Stay away from the ultra processed foods, refined sugars, inflammatory seed oils. If you have sensitivities, to gluten or dairy, then, stay away from those, because we have to eat to live. Well, then eat to live. All right. And make sure that you are supporting your body for that. Another thing is, like what Dr. Kosterman and Justin have talked about, the gut biome, the oral and the gut biome. So you want to improve your gut health, and, offering your microbiome the good foods to feed them aligns right in with the types of foods that you are eating. Also supporting your methylation pathway, having foods that are rich in your B vitamins, or if you're taking supplementation, taking the forms that are right for you genetically. Also the stress. Stress causes so much increase in cortisol, increase in inflammation. Finding ways to find joy, fun things, lowering your stress levels. That is huge, because by doing those things, it helps with the sleep, the blood sugar regulation, all of those wonderful dominoes that, tend to go. They all contribute to lowering inflammation.
Fun. Thanks, guys. All right. Our next question here is from, I think it's said Marissa. I hope I'm saying that right. And it's a little vaccine specific. So what do you think about the J&J? So this is Johnson & Johnson shot, better than the others since it does not have mRNA.
Yeah, messenger RNA. Yes. That's kind of a loaded question.
I'll speak to the stats first, maybe.
Yes. Why don't you speak to
yeah.
the stats, and then I can jump in with a little bit of information.
Yeah. So, if the ultimate goal of taking a vaccine is prevention, right? J&J, that shot was shown to not be as effective as other vaccines, in the sense that it was probably about a 66% efficacy rate in preventing marked episodes of COVID, right? And so not necessarily as effective, if that's the one measure you want to look at. When we look at adverse effects, the common adverse effects were mostly the same across the board, right? So sometimes people get headaches, sometimes pain at sight, sometimes nausea, etc. The common, right? Now, where it becomes a little bit more tricky is more those rare and problematic side effects. And so this would be your thrombosis, and as well a relatively rare neurologic condition. And I don't know if I'm going to be saying this properly, but Guillain-Barré syndrome, which is an instance where it's an immune instance where the body kind of attacks nervous cells. Not necessarily fatal, can be. So the risk profile for this one is a little bit more marked, relatively speaking. And so I believe it is no longer being used. Hold me honest there. I think it's, yeah. So I think you can travel abroad and potentially get it. Someone hold me honest on that one, but I believe within the Americas, Canada, US, Mexico, I do not believe you have access to it anymore. Largely in part because of side effect profile relative to efficacy profile. Dr. Varden, anything to add there?
Well, actually, you've covered that quite well. And I know that we have a few more questions to get to, and we're coming close to ending our evening. So I don't want to overrun our time here.
Okay, so Janice is asking a question. Hey, Janice, you another frequent offender. I've heard that there's not much you can do to lower your lipoprotein A because it is genetically determined. She's offered her result. Is there a way to mitigate this, genetically speaking?
I think really, like Dr. Varden gave a really good explanation earlier about LDLs and these different lipids in the body. And the theme that keeps coming up is the management of inflammation, because that's really why your body is releasing these cholesterols in the first place. We also have genes like PCSK9 that are relevant there for like LDL receptors, which if you haven't had your DNA 360 done, I would have a look at that. I would also look at ApoE, as well, for example, because that really is determinant of how efficient your body is at using cholesterol in the first place to be dispersed and then pulled back to the liver and addressing the inflammation that's present. My advice would be to really manage inflammation and understand where it's coming from, and then also improve detox capacity, because those two moving factors together are really what make cholesterol numbers matter. Like I think that it's really about the management of those two systems. So look at your DNA 360 if you have it and understand where your body isn't managing inflammation well and where it isn't detoxing well. And if you have interventions to help upregulate those mechanisms, it'll probably help. That's more of a general recommendation, though. Ladies, you have anything extra to add to that?
Well, I wanted to mention that when you were born, your LP little a wasn't super high. As a child, I'm sure if you had, that tested, it probably wasn't, really high. It is due to diet, lifestyle factors, stress, that inflammation, that toxic load that accumulated, that allostatic load, that brought it to that number at this point in time in your life. I don't like the extremes of never, you can't do this, you can't, because I'm always one, it's like, oh, really? It's like, let me prove you wrong. I love how Justin just, explained, looking at the systems, looking at, different aspects of your genetic profile and working that. And it goes back to what I was saying in the beginning of cleaning up the terrain, because we have to be careful about focusing on the leaves and the branches of the tree. Okay, because that's what we're doing when we're only looking at, the marker of LP little a. All right, there's more going on. These genes, these markers do not exist in a vacuum. So our bodies are miraculous things in the fact that we are always in a healing state. Our bodies can heal. We just have to get out of its way and provide it the materials, those basic building blocks it needs to do the repair. So I would say, use your resources, have the knowledge, and then clean up your soil and terrain. And a lot of those markers and numbers and issues down the line, those limbs and the leaves will fix themselves.
Thank you. Carl has put in a question. It's a little bit of an anecdote speaking to what I think is vaccine injury. And so, Carl, if you want to reach out to us, if you're looking for some support, our Chief Medical Officer, Dr. Boyce Burkle, can support vaccine injury. It's a very specific protocol, but it's something we can help you with. I didn't fully catch the story, so but do reach out to us if you want some support there. Okay. Our last question of the night, and I really like this one because it's a happy little kind of round up the conversation of heart disease. Sandy is asking, in addition to genetic testing, what are the top labs you think are most important to evaluating possible concerns for heart health? Are there any, or can you talk about the benefits of unconventional labs or data? I'm gonna expand this to data outside of labs, because she's asking around like HRV, etc. So I know we've kind of already said there's an element of personalization. My panel comes out of Boston University. That tends to be my favorite, but I like that she introduced into this questions that have more dynamic data. And by dynamic, I mean, if you take a blood test, that's one point in time. And if you take several, you have some dynamicism, you have some changes over time. But I like that she introduced other things like other metrics. So when I think of heart disease and cardiovascular health outside of blood work, my favorite, and this is founded in several studies, one of the best ways to know your cardiovascular health is take a measurement of your waist. And so I found this is actually a better predictor of heart disease in people than blood work is. There's kind of this fun study that took doctors and they said, look at blood work and then look at, and then do the analysis of waist, hip to waist ratio, right? And that was stronger in predicting or at least understanding heart disease necessarily than blood work. And again, that's one instance of blood work. There's something to be said when a clinician looks at several instances, but as basic as that is, my favorite non-lab thing is measurements. Where do you guys sit in this?
I would recommend our Gut 360, honestly, straight up.
Ooh,
DNA code
fun.
Gut 360, which by the way, there's now a premium version of, which is way
Mm.
more detailed and has a lot of moving parts. But we continuously bring this conversation back to inflammation being, a pretty big root causal factor here. And I think a lot of it for a lot of people is stemming from that gut, and you're not going to know until you test it. So have some kind of a gut assessment done, because dysbiosis in there is a constant trickle of inflammation. And once again, every system in the body, bring it back to what I said earlier, where does the gut begin and end? Where does the cardiovascular system begin and end? There's a relationship between all of these different things. So get a measure of what's happening in that gut, and you'll know a lot about your inflammatory profile.
And I'm going to touch on what she had asked about as far as how HRV is beneficial.
Mm.
And really, when you're talking about HRV, now what is that? That's heart rate variability. And this actually is a good indicator of the ability of your heart to adjust. It's an indicator of the health of your body, because put it this way, when we are stressed, when we are in the sympathetic mode, okay, our heart beats faster and more rhythmically, where there is very, very little variability, okay? So it's very synchronous in the way that it's beating, okay? When you are in the parasympathetic state, that rest and digest, that calm, there's a lot more variability in the timing of your heartbeats. And yes, actually, that's a better thing. So the more variability, the larger of the timing of variability you have, it is reflective for the amount of time you are spending in that parasympathetic rest and digest state. Okay. And this is reflective on things like the Oura ring, that keeps track of that. And there are other trackers that you can check. So ways that you can, well, first of all, studies have shown that a low HRV, okay, when you are in that sympathetic stressed state, it is linked to higher CRP. Remember, I mentioned the C-reactive protein, that systemic inflammation. It is also linked to things like increased risk of heart attack and sudden cardiac death. It is also linked to poor nitric oxide production and endothelial dysfunction. Okay, so what do? Well, we want to increase our heart rate variability. How do you do that? Through things like breath work. That improves the vagal tone, the vagus nerve, that wandering nerve that when activated, activates your parasympathetic state, that rest and digest. Having things like morning sunlight and regulating your circadian rhythm, that helps with that autonomic balance. Doing different things like infrared sauna or cold exposure, doing these temperature contrast therapies because they improve vascular function. Strength training, zone 2 cardiac workouts, improving your mitochondrial efficiency, making sure that you stay hydrated, using electrolytes, because the magnesium, potassium, sodium, these help to stabilize your heart rate variability. And of course, hey, if you want to go and try some nootropics or things like that, in order to modulate the cortisol, the stress hormone, things like L-theanine, phosphatidylserine, adaptogens are always, interesting and useful. So there are different things that can be done that you can do to help your heart rate variability, cardiovascular health. And this is just the beginning, and we can personalize that to you based on your genes, based on your history, based on your current stresses and everything else you've gone through by, coming in and having us help you by looking at some of our programs.
I think that's that. But before we lose our audience, and with awareness that 75% of our audience, who knows how much is left, but 75% is female, I think this is still really important. I want to announce what we're doing next week in particular, because we have someone representing from the host panel here. But I know women are on, and don't tune out, because statistically speaking, it's the women of the household that make the healthcare decisions. And so you're advocates for everyone involved. Next week, we are hosting a He Summit, and the topic, this mirrors the She Summit that we hosted a month ago. Dr. Varden, hold me honest. I think it was a month ago. I was in the range. I'll take it.
Well, it will be a month next week when we have our He Summit.
Touché. There we go. I like when you give me a gold star for trying. So we at the DNA Company were really focused on how do we support topics of health that are of concern to men and of to women. So last time for women, we tackled osteoporosis. We're going to be doing another one in 5 weeks that's going to tackle infertility. But next week, Justin here is going to be part of a panel that is going to be exploring erectile dysfunction, which impacts both men and women, or at least straight women it impacts. So.
Yeah, and by the way, it can be an early warning sign of cardiovascular issues as well. So it's a great indicator there, and I recommend, if you have either of the above, showing up to the Men's Health Summits, because we got a big old panel, myself included, 3 days worth of talking about erections. So it should be a lot of fun.
Going to be delightful. All right. So to our audience that has stuck with us, thank you so very much for joining in. Thank you for being advocates either to the young or to those that have been exposed to COVID through whatever mechanism. We're so grateful that you are here this evening. Lara, Justin, y'all are bomb diggity, and I'm so very grateful that I get to have these conversations with you too. Thank you. Thank you for the perspective and the energy that you bring to this all.
Thank you. And thank you everyone for joining us.
Yeah, I think it's time we dance out. All right. Au revoir, mes amis. Au revoir.
Bye, everybody. See you next week.
Au revoir.